Tooth eruption and exfoliation. The term exfoliation also refers to the shedding of leaves in autumn, and the same term is also used with reference to the shedding of deciduous tooth and the replacement by the permanent teeth. The physiological tooth movement comprises of three types of movement. Those before eruption are the pre-eruptive movements. This is followed by the actual phase of eruption of the tooth into the oral cavity. And following this, there are the post-eruptive movements. Pre-eruptive movements are those made by the tooth germ within the jaw prior to and in preparation for eruption. This phase ends with the initiation of root formation. Pre-eruptive movements in the anteriors, the deciduous tooth germs are usually located in slightly lingual position, and the permanent tooth buds are lingual and apical in relation to the permanent tooth. When we look at the premolars, we can see that they are placed lingual and then later between the flared roots of the deciduous molars. Now, in this stage of pre-eruptive movements, the histology involves both bodily movement as well as eccentric growth and bone remodeling and growth of the children's jaws. Post-eruptive movements, on the other hand, after the tooth has attained its position in the occlusal plane, these help to maintain the position of the erupted tooth within the jaw as the continued growth of the jaw proceeds. Now, this also compensates for occlusal and proximal wear as the tooth ages. Now, for a detailed look at eruptive movements can be defined as the axial or occlusal movement of tooth from the developmental position within the jaw to the functional position in the occlusal plane. The eruptive phase starts with the initiation of tooth development and later ends when the teeth reach the occlusal plane or the occlusal contact, when it comes into contact with the opposing tooth. The histological changes that comprise the eruptive phase of tooth movement, there are four major events. The first is the formation of root. So for a tooth to erupt, the roots have to form, and along with root formation, there will be corresponding formation of the periodontal ligament, and in the appropriate time, the dentogingival junction forms, and two peculiar structures which are seen in an eruptive phased tooth are the gubernacular cord and the gubernacular canal, which are seen usually in successional teeth. This is a schematic representation of the different phases of tooth eruption. In the early phase, there is the oral epithelium and the tooth bud forming here. And as the tooth continues to develop, the alveolar bone develops, and there is the distal extension or the lingual extension, which comprises the permanent tooth bud. Now, as the deciduous teeth continues to form, correspondingly, the permanent tooth also forms within the jaw bones. And once the deciduous tooth has erupted and has outlived its time of function, the permanent tooth starts to develop within the jaw and it replaces the deciduous teeth. So this can be seen as A in the bud stage, later the cap stage, the bell, calcification of the enamel matrix for the deciduous tooth, formation of the root of the deciduous tooth, followed by resorption of the roots of the deciduous teeth as the permanent tooth start to form and erupt. In the histology of eruption, the formation of the root comprises the following stages. The first is the formation of the cervical loop. The inner and the outer enamel epithelia reflect in on each other and they form the cervical loop. The cervical loop continues to extend downwards to form a sheath called as the Hertwig's epithelial root sheath. This sheath is what gives rise to the root dentin or radicular dentin. This results in disruption of the Hertwig's epithelial root sheath. Following this, the dental follicle and the root dentin interaction begins, which results in formation of the periodontium. Histology of eruption involves initial stage, the tooth moves occlusally through the bony crypt of the jaws, and there will be loss of the intervening connective tissue and fusion of the reduced enamel epithelium and the oral epithelium. Fusion of the reduced enamel epithelium covering the tooth crown with the oral epithelium results in a solid plug of epithelial cells ahead of the erupting tooth. Now, the central cells of this epithelial plug will degenerate to form an epithelium-lined tract through which the tooth erupts without hemorrhage, and it also contributes to the formation of the dentogingival junction. This is the reason why deciduous teeth can usually be shed without much bleeding from the erupted or the shed tooth site. Histology of eruption. To continue, the eruption process will then continue until the tooth reaches the occlusal plane, and the rate of eruption within bone is usually 1 to 10 micron meters per day. Once it leaves the bone and comes into the extraoral, the soft tissues of the oral cavity, the rate of eruption is much faster and proceeds at about 75 micron meters per day. Now, to take a look at the peculiar structures that we see in successional teeth during the phase of eruption is the gubernacular cord and the gubernacular canal. The gubernacular cord is a follicle surrounding the successional tooth, and it retains the connection with the lamina propria of the oral mucosa by means of a strand of fibrous tissue which contains some remnants of dental lamina. This is what is known as a gubernacular cord, or also called as a gubernaculum dentis. The gubernacular canal, on the other hand, is a hole in the bone or canals in the bone which contain this soft tissue component or the gubernacular cord. And its significance is that it helps in guiding the permanent tooth towards eruption. Coming to the mechanisms of exfoliation or tooth eruption, there are four main theories related to tooth eruption, and these are the root formation theory, bone remodeling theory, vascular pressure theory, and the periodontal ligament traction theory. Now, we need to understand that tooth eruption is a multifactorial process, and there are contributions from all of these theories. But the main ones which have withstood the test of time are the bone remodeling theory and the periodontal ligament traction theory. The first theory says that the proliferating root causes an overall increase in length of the tooth, and this increase in root length is translated into occlusal movement of the tooth. Now, there are certain factors which go against this root growth theory, and the first one is that teeth tend to move a greater distance than the length of the fully formed root. So, it does not fully translate as the same root length does not translate into movement. There is greater movement. The second is that the onset of eruption is not synchronous with the onset of root formation. Third reason against the root growth theory is that there is a lack of a fixed base for the root of the tooth to be fixed on so that it translates into occlusal movement. Previously, a histological structure was thought to act as a fixed base. That was the cushion hammock ligament, which was seen at the base of the tooth socket. But however, this is a limiting membrane and it is not a fixed base. The last reason which is cited against the root growth theory is that rootless teeth, which is seen in the dentine dysplasia, which is a dental anomaly, can also erupt. So even without formation of root, the teeth can erupt. So these are the factors which go against the root growth theory. In conclusion, the root formation per se is not required for tooth eruption, although it can accelerate the process of eruption. The next theory is the bone remodeling theory, where selective deposition and resorption of tooth brings about eruption. In this theory, the main player is the dental follicle, the tissues of the dental follicle. And it was found that when the tooth germ was removed and a metal or a silica replica was placed in place of the tooth germ without damaging the dental follicle, then even then an eruptive pathway formed. So definitely the dental follicle and not the actual tooth germ, had a role in the eruption of the tooth. Now, however, if the dental follicle is also removed in this experiment, no eruptive pathway is formed. So the conclusions drawn from the bone remodeling theory were that programmed bony remodeling does occur during eruption, and the dental follicle is an important structure in this aspect. So what is the role of the dental follicle in tooth eruption and in bone remodeling during eruption? Cellular activity and signaling molecules produced by the dental follicle and the reduced enamel epithelium can help in connective tissue degradation and in remodeling the bone during eruption. The factors involved are bone resorptive factors produced by the dental follicle, which include TGF beta and CSF1. Both of these have a role, along with bone formation, which is stimulated by CBFA1, which is core-binding factor alpha. So we can see that the dental follicle produces both bone resorptive factors as well as bone formative factors. This is a flow chart showing the role of the dental follicle in the various and the molecular determinants of eruption. The dental follicle produces TGF beta and CSF1, which have a role in bone resorption, while epidermal growth factor and CBFA1 have a role in bone formation. The next theory, or the vascular pressure theory, is the one which is least cited, and this states that a local increase in tissue fluid pressure in the periapical region can produce some amount of tooth eruption. The periodontal ligament traction theory, which is widely cited, says that periodontal ligament fibroblasts have the ability to contract and can exert a tractional force onto the tooth through the collagen fibers or by the cell-to-cell fibroblast contact. Here also, the dental follicle, along with the periodontal ligament complex, has an important role. So the eruptive force is thought to reside in the dental follicle PDL complex. In a nutshell, the periodontal ligament traction theory states that the PDL fibroblasts contain contractile filaments. The periodontal ligament fibroblasts also maintain cell-to-cell contacts and cell-to-matrix contacts via the fibronexus. And the cell-to-cell contact, that is the fibroblast to fibroblast contacts, results in a summation of the contractile forces, which can result in eruption. On the other hand, the cell-to-matrix contacts, that is the fibroblast cell to the collagen matrix via the fibronexus, transmits the forces to the collagen fiber bundles, and these fiber bundles get aligned and angulated in the correct angulation, which results in remodeling of the periodontal ligament, resulting in eruption. Now, along with this, there will be selective or deposition and apposition of bone in the pathway of the eruptive tooth. The factors which favor eruption in this theory are the PDL remodeling capacity, the fibroblast contractility, and the presence of the fibronexus, which is a material which binds the cell to the matrix. This is a picture of the structure of the fibroblastic cell, or the myofibroblast, which is the kind of cell which is seen in the periodontal ligament. It is a differentiated fibroblast which has greater contractile functions due to the presence of the actin and myosin filaments. The experiments favoring the PDL theory include root resection and root transection of rodent incisors, which show that the teeth will continue to erupt even when the root is cut. Also, the presence of the periodontal ligament, as long as it is maintained, it can continue the eruptive pathway. So the dental follicle, periodontal ligament is the possible source of eruptive force. Factors which go against the PDL theory include experiments with laterogens. These are drugs which inhibit collagen cross-linkage, which can disrupt eruption. Also, cases occur in which PDL is present, but the tooth do not erupt. So whenever the collagen cross-linkage, which is an important factor in the PDL remodeling theory, is disrupted, this can result in lack of eruption. The concept of continuous tooth eruption was given by Gottlieb, who gave that eruption occurs in two phases, the active phase and the passive phase. The active eruption is the movement of the tooth into the occlusal plane, as we just saw, while passive eruption occurs in four stages. In the first, and that is caused by downward shift of the dentogingival junction. So passive eruption results in is from apical migration of the dentogingival junction onto the cementum of the root, and it results in an increase in the length of the clinical crown of the tooth. With that, we come to the end of eruption. Thank you.